Premenstrual syndrome, PMS, comprises a predictable cluster of physical and emotional changes that arise in the luteal phase of the menstrual cycle, typically a few days to 2 weeks before menstruation begins. These changes are the body's way of signaling that the endocrine environment is about to revert from the progesterone-dominant state back to the estrogen-dominant follicular phase. Clinically, the syndrome is identified by its cyclical pattern. Symptoms appear consistently before menses, subside with the onset of flow, and reappear in the next cycle. The hallmark of PMS is its variability. While many people experience mild, almost unnoticeable fluctuations, others report severe disruptions that can affect daily functioning. Recognizing PMS as a normal physiological response, rather than a pathology, helps clinicians differentiate it from other mood or somatic disorders. The precise etiology of PMS remains multifactorial. Hormonal oscillations, particularly the rise and abrupt fall of estrogen and progesterone during the luteal phase, alter the synthesis and reuptake of neurotransmitters such as serotonin and gamma-aminobutyric acid, GABA. These neurochemical shifts can amplify mood lability and pain perception. Concurrently, lifestyle factors, chronic stress, irregular sleep, low glycemic diets modulate the hypothalamic pituitary adrenal HPA axis, exacerbating the hormonal neurotransmitter interaction. Genetic predisposition also plays a role. Polymorphisms in the serotonin transporter gene 5-HTT-LPR have been linked to heightened PMS severity. Think of the endocrine system as an orchestra. The conductor hormones changes tempo, and if the musician's neurotransmitters, metabolic pathways cannot keep pace, discordant symptoms emerge. During the luteal phase, the corpus luteum secretes progesterone and maintains moderate estrogen levels. If fertilization does not occur, both hormones precipitously decline over 2 to 3 days. This swift withdrawal reduces serotonergic activity by decreasing tryptophan availability and altering receptor sensitivity, leading to lowered mood, heightened pain, and irritability. Moreover, progesterone withdrawal affects GABA, a receptor modulation, which can increase anxiety and sleep disturbances. The resulting neurovascular changes, such as vasoconstriction of cerebral vessels, contribute to headaches and breast tenderness. The pathophysiological cascade can be visualized as a dimmer switch that abruptly dims the brain's lighting, serotonin, and GABA pathways, creating a temporary state of darkness and discomfort. Epidemiological surveys indicate that approximately 75 to 80% of menstruating individuals notice at least mild PMS symptoms, while 20 to 30% experience moderate to severe forms that impair occupational or academic performance. The prevalence is consistent across continents, ethnicities, and socioeconomic strata, though severity tends to increase with higher stress levels and poorer dietary patterns. Incidence peaks in the late teens to early 30s and often declines after menopause when cyclical hormonal fluctuations cease. Longitudinal cohort studies suggest that a family history of mood disorders modestly raises the risk of severe PMS, underscoring both genetic and environmental contributions. Typical PMS manifestations span affective, somatic, and behavioral domains. Affective symptoms include irritability, sudden mood swings, dysphoria, heightened anxiety, and reduced stress tolerance. Somatic complaints often involve abdominal bloating, breast engorgement, low-grade headache, joint or muscle aches, and fatigue. Behavioral changes may appear as food cravings, especially for sweets or salty snacks, reduced libido, and sleep disturbances. For instance, a woman might notice a sudden craving for chocolate paired with a feeling of being unusually on edge 5 days before her period, which resolves once menstruation begins. These symptoms are confirmed only when they follow a reliable temporal pattern, across at least 2 consecutive cycles. Diagnosing PMS is principally clinical and relies on prospective symptom tracking. The gold standard approach uses a daily rating scale, such as the Daily Record of Severity of Problems, DRSP, over 2 consecutive cycles to verify the cyclical nature, symptom severity, and functional impairment. Differential diagnosis mandates exclusion of endocrine disorders, thyroid dysfunction, hyperprolactinemia, psychiatric conditions, major depressive disorder, generalized anxiety, and other gynecologic diseases, endometriosis, dysmenorrhea. Laboratory tests are generally reserved for atypical presentations. A diagnosis of premenstrual dysphoric disorder, PMDD, requires that at least 5 symptoms, including 1 mood symptom, appear in the final week before menses, cause marked distress, and are confirmed by prospective charting. Mild symptoms are noticeable but do not limit work, school, or social activities. Example, slight bloating and occasional irritability that resolves without intervention. Moderate symptoms cause noticeable difficulty in concentration, productivity, or interpersonal relationships, requiring occasional over-the-counter analgesics or lifestyle adjustments. Severe PMDD symptoms are sufficiently intense to impair functioning, often accompanied by suicidal ideation, severe depression, or marked anxiety, and typically demand pharmacologic therapy, SSRIs, hormonal agents. Clinicians use severity scales such as the Premenstrual Symptom Screening Tool, PSST, to categorize patients and guide treatment intensity. Management begins with non-pharmacologic strategies. Regular aerobic activity, greater than or equal to 150 minutes per week, enhances endorphin release and stabilizes serotonin. Balanced nutrition emphasizing complex carbohydrates, calcium-rich dairy, magnesium-rich nuts, and omega-3 fatty acids mitigates mood swings and cramping. Sleep hygiene, 7 to 9 hours per night, and stress reduction techniques, mindfulness, progressive muscle relaxation, further attenuate symptom severity. Analgesics, NSAIDs, ibuprofen 400 to 600 milligrams every 6 to 8 hours for dysmenorrhea. Nutraceuticals, calcium 1,000 milligrams per day, magnesium 300 milligrams per day, vitamin B 650 to 100 milligrams per day, and chasteberry, Vitex agnus castus, 400 milligrams per day, shown to modestly improve mood and breast tenderness. Selective serotonin reuptake inhibitors, SSRIs, fluoxetine, sertraline, or escitalopram, either continuously or intermittently during the luteal phase for premenstrual dysphoric disorder. Hormonal therapies, low-dose combined oral contraceptives or continuous-use progestins to blunt hormonal fluctuations. Treatment is individualized. A stepwise approach, starting with lifestyle changes, then adding supplements, and progressing to medication for refractory cases, optimizes outcomes while minimizing adverse effects. Preventive measures mirror therapeutic recommendations and focus on maintaining hormonal steadiness. Daily aerobic exercise, regular meals with low glycemic index foods, and adequate calcium intake 1,200 milligrams for adults create metabolic stability. Reducing caffeine less than 200 milligrams per day and alcohol less than 1 drink per day lessens estrogenic fluctuations and insomnia. Tracking symptoms with a mobile app or paper diary helps individuals recognize early patterns and apply interventions before symptoms peak. Some clinicians recommend prophylactic vitamin D 1,000 to 2,000 international units per day or omega-3 fatty acid supplementation EP/DH, a 1 gram per day based on emerging evidence of anti-inflammatory and mood-stabilizing effects. The long-term outlook for most individuals with PMS is favorable when evidence-based interventions are applied. Symptom severity typically declines after menopause as cyclical hormonal variations cease. For those with PMDD, chronic management with SSRIs or hormonal regulation often yields sustained remission, though occasional symptom flare-ups can occur during life stressors or medication discontinuation. Importantly, untreated severe PMS can contribute to secondary mood disorders, relationship strain, and reduced quality of life. Therefore, early identification and tailored therapy are essential to prevent chronic psychosocial sequelae. Current investigations are expanding the mechanistic framework of PMS beyond the classic hormone neurotransmitter model. Gut-brain axis studies suggest that dysbiosis, particularly reduced lactobacillus and bifidobacteria, may amplify systemic inflammation and serotonergic dysregulation, prompting trials of probiotic supplementation, for example Lactobacillus rhamnosus GG, that have shown modest mood benefit in pilot cohorts. Genomic analyses have identified single nucleotide polymorphisms in the ESR1, estrogen receptor alpha, and SLC6, a 4 serotonin transporter, genes that predict heightened PMS susceptibility, opening avenues for personalized pharmacotherapy. Additionally, low-dose extended cycle hormonal contraceptives that deliver constant hormone levels are being evaluated for their capacity to flatten luteal phase hormone swings, thereby reducing both somatic and affective symptoms. These emerging modalities hold promise for more precise, mechanism-based management of PMS and PMDD.